So at the EHA this year, we presented in behalf of my colleagues, particularly the first author, Dr. Geary, who is one of our junior colleagues, a meta-analysis of the impact of daratumumab in the treatment of multiple myeloma patients according to cytogenetic risk. We all know there has been multiple randomized phase 3 trials, both in the newly diagnosed setting and in the relapsed setting. And in the newly diagnosed setting, both in the transplant-eligible and non-transplant-eligible population, that compare backbone multiple myeloma regimens with the same backbone myeloma regimen with the addition of daratumumab. So in the newly diagnosed setting, we have Alcyon, we had Maya, and most recently, we had Cassiopeia in the transplant-eligible patients. And in the relapsed setting, we have now Castor, Pollux, and more recently, Candor. And while all those trials were positive in terms of progression-free survival, when you look at subset analysis, particularly for the trials in the newly diagnosed setting, it does not seem to be a significant advantage for patients with high-risk chromosome abnormalities, here defined as deletion 17p, translocation 414, and translocation 1416. So that has raised some concern that perhaps, at least in the newly diagnosed setting, daratumumab may not add any to those regimens in patients with high-risk chromosome abnormalities. However, an alternative explanation, and this might have to do with the low sample size, with the underrepresentation of high-risk patients on those studies, or perhaps even a shorter follow-up, or perhaps even a real but yet diminished effect in high risk as compared to standard risk. So in order to try to address that question, we perform a methodologically rigorous meta-analysis, essentially looking at the entire literature, both published literature as well as abstract presented in meetings, for all trials that compare backbone myeloma regimen versus that backbone plus daratumumab. And we came up with the 6 trials that we already cited. And then we look at the impact in PFS for both standard risk as well as high-risk patients. So in the newly diagnosed setting, when you look for standard risk, the benefit of daratumumab was pretty obvious with a hazard ratio of 0.45, and it was statistically significant. But when you look at a high risk, for the first time, we demonstrated that benefit was also significant with a hazard ratio of 0.67, with a confidence interval of 0.47 to 0.95. So it's statistically significant. In the relapsed refractory setting, we saw a very similar picture with a significant hazard ratio of 0.38 in the relapsed refractory setting and 0.45 in the newly diagnosed setting. So we think this study is very important because reinforce here the notion that the reason why those individual trials were not didn't show significant PFS improvement in the high-risk subsetting has to do mostly with the small representation of high-risk patients on those trials and shorter follow-up, and somewhat slightly diminished biological impact that daratumumab has in high risk as compared to standard risk. Nevertheless, in the newly diagnosed setting, daratumumab still reduced the risk of death or progression by 1/3 with a hazard ratio of 0.67, which is really important for this very difficult to treat patient population. While those trials were, of course, different in terms of what backbone regimen or even what population they include, we did formal testing for heterogeneity, and there was no significant heterogeneity across the studies, suggesting here that the impact of daratumumab, the benefit of daratumumab, does not seem to be context-specific or regimen-specific. So this seems to have an impact really regardless of what the backbone regimen is.